Good afternoon, everybody. I'm Pierre Carlier, so I will be the speaker today. I've been asked to introduce myself. I'm a Belgian physician, being trained at the University of Liège quite some time ago. I also got my PhD in biomedical science from the same university, and I got an interest in what I still prefer to call NMR very early on. And for the anecdote, it was during my final examination, my final exam in surgery, that the professor gave me a reprint mentioning that we could measure blood flow with NMR, and it was the start of a career. So I was initially a cardiovascular researcher with an interest in NMR application, particularly spectroscopy. And about 25 years ago, I joined the French Atomic Energy Commission, where we were mainly busy with muscle spectroscopy and muscle imaging. And well, now I'm the head of the NMR laboratory at the Institute of Myology. That's a joint venture between CEA and the Institute of Myology, where we developed all sorts of muscle application. My main interest, the main interest is more on the development of NMR imaging and spectroscopy as biomarker, as outcome measure for clinical trials. But today we will be busy with the use of imaging as a diagnostic tool, and I shall review with you what we can call the basics. So these are my disclosures. And as you know, the skeletal muscle can be affected by a great many conditions. It can be secondarily in systemic disease, like consequences of arteriosclerosis, diabetes, not only type 1, also type 2, also in connective tissue disease. When the muscle is the primary target, it can be hit by trauma. It can also be affected by infections. Well, and clearly imaging as a role, sometimes a specific role for all these diseases. It's not the topic of the today webinar. We'll touch a little on the role of imaging in the inflammatory myopathies, where it's particularly important, dermatomyositis, polymyositis, and so forth. But we shall mainly focus on the hereditary muscle or neuromuscular condition. If you have a look at the gene table that is maintained by Professor Kaplan, that you will see that we are now very close to 1,000 muscle hereditary disease with more than 500 genes identified. So there's quite a lot of things. When the muscle is when we are talking about a disease of hereditary origin, the primary defect can be at the level of the muscle fiber or at the neuromuscular junction. It can also be in a consequence of a nerve disease or a problem with the second motor neurons. In these two instances, the muscle is then secondarily affected, altered by the denervation process. And depending on the condition, depending on the disease, well, the role of imaging will vary. For myasthenia, for instance, as well as for metabolic disease, well, imaging has very little to offer. It can be of interest in other conditions, neuropathies, certainly also for spinal muscular atrophy. And there are a number of instances where the role of imaging can be extremely important. This is the case for the dystrophies. It is also the case for some congenital disease, particularly the myofibrillar myopathies, and also for the difficult category, difficult to investigate, of distal myopathies. Now, the skeletal muscle characterization by NMR imaging is being operated at 2 levels. Well, you can estimate the muscle trophicity. Also, you can evaluate the existence, the extent, and the severity of the chronic degenerative changes. And you know that there are two main categories. It can be either fibrosis, and for this, there is really no imaging solution at the moment, unfortunately, but fatty replacement can be very nicely, precisely determined. And the third level of characterization is in radiology textbook commonly referred to as the detection of inflammation. Well, we prefer to call it disease activity because there are many other circumstances that can result of what you call in the neurology jargon stir positivity. By that we mean an increase in the Water32. We'll come back to that later. Now, MR imaging is the preferred technique for muscle investigation. Well, why is it so? Well, it's due to the quality of the images that are produced, the 3D versatility, the non-invasiveness of the technique. But to be honest, both trophicity and the chronic degenerative changes, at least in the hands of experts, particularly for the ultrasound, can be also nicely investigated. What makes MR superior is the ability to detect lesions, inflammation, edema. Very, very difficult with the other technique. There's more, and it's sometimes forgotten that MR is much more than anatomical imaging. That anatomical imaging will be the topic of the day, but with the NMR techniques, you can also really perform in vivo studies of muscle physiology and muscle energetic biochemistry, which can be profoundly altered in disease, and you can get relevant information. And one of the new novel use of these functional and metabolic studies is to extract biomarkers for the evaluation of therapies. Now, coming back to the diagnostic imaging in routine condition, well, a standard diagnostic imaging protocol will almost always be a qualitative one, which means that you're going to use UIs. It's by visual inspection and also possibly by semi-quantitative grading that you will evaluate the situation. A very basic skeletal muscle imaging protocol will always start with a T1 weighted spin echo sequence. Why? Well, it is a very common, it's a very standard sequence, and it's nicely discriminated between three key tissue. The muscle tissue as an intermediate tone, the fat tissue appears very hyperintense, while the connective tissue, if it's dense enough, like in the cortical bone, in the fascia, appears as profound hypointensity. So very nice contrast and nice delineation of the anatomical structures. Then very often, if not systematically, you will perform a second sequence that is often referred as TER. It's an erroneous denomination. It is in fact a fat saturated, that's what STIR is doing, T2 weighted spin echo sequence. That you have an example here, and it allows you to detect areas of inflammation or lesions. You can do about the same after gadolinium injection. You have an example on the right. There's some advantages with the gadolinium injection in terms of identifying better the underlying mechanism. And this is nowadays largely offset by the need of injecting gadolinium and concerned about the possible long-term toxicity of at least some forms of gadolinium complex agent. That's why it's all nowadays almost exclusively the T2 weighted sequence that you would run. And you would do that minimum in the lower limbs, thigh and legs, always systematically in axial orientation, and if needed also in coronal orientation. So with that, you can roughly appreciate the muscle trophicity at some sort. It remained some sort of rough estimate, because you can just say, well, it seems to me it's hyper, pseudo hyper, when the leg has a big volume, but it's likely due to fat infiltration. Next is to look for the existence of fatty replacement within the muscle, and you can detect that very well because fat is strongly hyperintense in a T1 weighted image. And there are different ways to grade the degree of fatty replacement. You go from the minimum when the muscle appears normal up to the maximum here from 0 to 4 when the muscle is strictly isointense with the subcutaneous fat indicating that the muscle is totally replaced. We prefer to use a slightly simpler grading, which go from 1, which is normal, 2, when we think that is less than 30%, 3 when it's less than 60% replacement, and 4 when it is more. It does not really matter. There's if you're consistent with your rating. Also, just to mention that just for this application, well, CT, if there's the only available imaging procedure, will still do the job because you also can detect and evaluate semi-quantitatively the fat infiltration. Simply, the contrast is opposite. Now, more important than grading, the existence of patterns. And as a neurologist, when you are seeing a patient with a muscle condition, well, the very first question that you are always systematically asking yourself, well, is it neurogenic or myogenic? And to that, EMG is key, with a clear different EMG in case of denervation with giant units, or in case of myopathic changes with small polyphasic units. And interestingly, there is some sort of equivalent with imaging. In neurogenic images, well, you have the situation like here, where you have a juxtaposition of tiny spots of, well, sometimes hypointense, probably fibrosis, normal and fatty areas. So it's extremely patchy. Patchy to the point that, like, look here, it becomes difficult really to recognize the muscle contour. This is a typical myogenic pattern. Well, to the opposite, when it is a myogenic condition, well, while the degree of involvement can be very different from muscle to muscle, look here, the tibialis anterior is preserved, the perineal group is affected. Well, within each group, it's still relatively, within each muscle, it's relatively homogeneous. And particularly clear here. So you have very different patterns. But much more. These patterns can be, and we have to stress that, can be disease specific, depending on the gene that is responsible for the disease. Well, we can have very different patterns of fatty infiltration, and this sometimes for the same clinical presentation. Why is it so? It's kind of a mystery. There's some clue, probably related with the ontogeny. We tend to see the muscle development as something that's relatively homogeneous and equivalent in all muscle. It's not true at all. So it's very likely, and some indication of that, these are the muscles where the gene is the more expressed, that are the more severely affected when the gene is pathologically mutated. Well, whatever. I mean, then the intellectual process that we are following is just the opposite. You start from the clinical presentation, then you look on the images if you can recognize a pattern that can be suggestive or sometimes absolutely specific to a particular gene mutation. So in a sense, it is some sort of intellectual game, and it's illustrated here by the quiz that was prepared by Volker Strobe. You can find the document on the internet. It's a very nice educational paper that was produced for the EN meeting, where really starting from a presentation of images, you have to try to pass and to identify sometimes. And you have here a number of specific situations where the images give you with no doubt the diagnosis. It's not always that nice. So let's just review a few of these diagnostic algorithms, where certainly imaging is useful is for the diagnosis of muscular dystrophy, and this is the diagnostic flow chart as is proposed. Well, you start by having a look at the thigh, and you look at where the involvement is the most severe. Is it posterior or anterior? Depending on that, then you have a look at the posterior lower leg. You look mainly at the gastroc and soleus and their situation. And you end up with proposal for at least the main muscle dystrophies. Of course, this scheme can be evolving. When it was proposed, anoctamin mutation were not identified yet, so we can modify a little the scheme by saying that while dysferlin and anoctamin patterns were very similar, dysferlins tend to be symmetric, while anoctamin is rarely symmetric. And in terms of shoulder and upper limb involvement, it's more frequent in dysferlin than anoctamin. When I prepared first this slide, well, it was, we could be very categorical about that and say yes and no. It's much less balance nowadays, and because we know, thanks to the very large study sponsored by the Jane Foundation, that in dysferlin patient, about 25% of patients with some degree of asymmetry. So, and the same for the shoulder. Initially, we were thinking that in anoctamin mutation, the upper limb would be preserved. No, it can be affected less often than dysferlin. So this is also an important message, that the more we know about these patterns, the more we can collect and accumulate cases, well, the more we must be cautious with the description of patterns. So there are trends, but there are always also exceptions. Another situation where imaging is extremely powerful is for the differential diagnosis of multiple myopathies. And the algorithm here is kind of simple. If you have preferential involvement of the semitendinous and the perennial group, well, the chance is very, very high that it's a desminopathy. If it's not the case, and if the semitendinosus to the opposite is less affected, then you just have to answer to a question. Sartorius more affected, the semitendinosus is adductor minus more involved in the gracilis. And if yes, then you're pointing to myotendinopathy. If not, you go one step down and you look at the involvement in the gastroc. If medial gastroc is more involved than the lateral, it's an argument in favor of the filaminopathy, and if not, then you end up with zaspopathy. Now, there are a few more genes that are involved in myofibrominopathy, but these are the most frequent. And if you look at the performance, and they've been reported, it is very high. Its sensitivity is almost 100% for the myopathy, and the specificity is always very high. So it was quite well. Another condition that you may want to investigate is spine rigidity. And there was a first paper by Mercury where the patterns were based on the lower limb examination only, with already a number of interesting observations. If the sartorius is preferentially affected, and sartorius, it's an interesting muscle and condition because sartorius is very often preserved. And also, and it was not noticed initially, but if the semimembranosus is very much atrophic or even possibly absent, well, this is a strong argument in favor of selenopathy. Well, for collagenopathy, there's, and we'll see that a little bit later, there's some sort of specific intramuscle involvement that give you with a very, very high probability the diagnosis. In the case of calpoinopathy, there's really a very much preferential involvement of the hamstring and the adductor magnus being particularly affected. And for the laminopathy, well, there are different cases. Well, sometimes it can be preferentially the lateral part of the quadriceps, but in other cases, it can also be the hamstrings. So you have patterns, and these patterns combined with some observation in the calf have also a quite good performance in terms of specificity and sensitivity. This one is an update taking advantage of the whole MRI that, and we'll see that later, is more and more important and popular. And it will help us, and it helps us to guide us for a few more diagnoses. Again, in the clinical condition of spine rigidity. And you can look, if you start, if the tongue is involved, which is quite rare, particularly in this condition, then you're left basically with two options. If you follow this one, well, you will see that you end up with the Pompe disease. So, because we know, and we review that also in a few minutes, tongue involvement and subscapularis involvement is a strong sign in favor of a pump. Now, it's not only the tongue, but also the sternocleidomastoideus is affected, then you end up in a very complex disease with very different phenotypes with the myosin heavy chain 7 mutation. Now you can look at the, starting at the sternocleidomastoideus, where you have 4 options. One we already seen. Sternocleidomastoideus, semimembranosus, sartorius, it's a selenopathy. Here, if you follow, and if you have with the gluteus maximus involved, the biceps femoris, and then you have the collagen sign, so you go back to the collagenopathy. We've seen also the myosin heavy chain, and there's a 4th option where the subscapularis is involved, the gluteus maximus is not too much involved, and you back on the lamin diagnosis. What whole body MRI can also identify for you, and it's not that often, if you have the temporal muscle that is fatty replaced, well, you just have to follow 2 main tracks. One will guide you to rear mutation, and we'll see that also later, because you have preferential involvement of adductor magnus and soleus. And the other option is for Merosin mutation, where here your brain scan will give you the diagnosis. So you see, you have a number of options, and you can sort it cases at least for some diseases. Distal myopathies are very, very complex pathologies, and we have here a very useful diagnostic algorithm that was initially proposed by Björn Uhl. The first one was about 10 years ago, and it is being improved, complexified almost every year. But as you can see, well, starting with the age of onset, well, introducing the information on the transmission mode if you have it, and then simply by looking at the preferential involvement of the leg, is anterior more affected than posterior, or vice versa, or is it mixed, then you have very useful suggestion on possible gene involvement. Now, there are also situations where muscle fatty replacement, simply by looking at the images, give you almost a diagnosis. It's true, for example, for tendinopathies, where you have always an involvement of the semitendinosus. If you remember, involvement of semitendinosus, it's also in favor of desminopathy, but in case of titin mutation, it is the anterior compartment, the tibialis anterior, sometimes also the tibialis posterior that involved, while in desminopathy, it is more the perennial loop. So semitendinosus and tibialis anterior makes you think of titinopathy. Another interesting situation now there's a quadriceps sparing, which is the gene myopathy, so the defective key enzyme to the synthesis of sialic acid. And you understand why it is known as quadriceps sparing, because this is the last muscle to be destroyed. And you see it very, very nicely. What is interesting is that at a very early stage, well, you have another sign, which is an early involvement, fatty replacement of the short head of the biceps femoris. And the short head of the biceps femoris, similarly as some other muscle, the gracilis, the sartorius, the rectus femoris, is more often spared than the others. So we have when you have a positive sign, like here, an early fatty replacement, this is a good indicator. It's a positive sign in favor of GNE myopathy. We've already mentioned the collagenopathy, which is easy to recognize because of the so-called tigroid fatty infiltration, particularly in the vastus lateralis, also in the deltoid, if you do the upper limb. If also this droplet sign in the rectus femoris, and in the gastrocnemius, this centripetal fatty infiltration. So it is highly suggestive. We were thinking that it was specific. Now we know that there are cases, some situation, a laminin deficiency, a calpain deficiency, where you can also sometimes observe a similar tigroid infiltration. But still, it remains very highly suggestive of this disease. Another interesting situation, an observation, which is that imaging allows as forces to reconsider some phenotypic classification. And you know that in this further mutation, at least two presentation, limb girdle, distal, also the proximal distal presentation. And well, quite surprisingly and interestingly, well, between different clinical presentation, I mean, the fatty replacement progression is not that different. In fact, it's very similar in the two conditions. Even more, the accordance, the degree of similarity between imaging and the genotype is superior than the correlation between the genotype and the histology. Very well illustrated here with another disease, with the rhinodine receptor mutation, where you have also rather specific patterns that I describe in a second, but for histological finding that can be relatively different. So when you are in a situation where you have the sartorius, not a rare condition where sartorius is affected, well, the gracilis is preserved, adductor longus is preserved while magnus is destroyed, rectus femoris is preserved while the rest of the quadriceps is heavily infiltrated, and in the hamstring, the semitendinosus is less affected. Well, this is very highly suggestive of rhinodine receptor mutation. One of the few other conditions where you have similar things is for the subject with which are heterozygous for the myotubular mutation. And that's it for the pattern. So there's already a whole lot you can do with a simple T1 weighted in terms of identification of patterns that will guide you to a possible diagnosis. So the next step is to use to launch a fat saturated T2 weighted image. And I It's on purpose that I've selected this image that is taken from a paper from Anna Pichetto, because you have what you call a stir positivity in the adductor magnus in this patient at the early phase under Pompe disease. Pompe disease known to have a very, very little, if any, inflammatory component. So just to indicate and to stress that a positive stir, so an increase in T2 in a muscle, it can be found in situations that are different than inflammatory changes. Just to review briefly how the contrast is involved in MR images. If you remember that you have three main parameters that control the image appearance, which is the proton density, T1 and T2. Well, you see that fat has a very short T1 that makes it that makes the T1 weighted sequence perfectly able to detect the fatty infiltration. Now, if you think about inflammation, edema, lesions, well, you see that it's rather the T2 that is increased. So you would favor, for the detection of lesions, T2 weighted sequences, and it works nicely. This is an example of a dystrophic mice model where you have regions with disease activity that are nicely depicted. Well, there's still a problem. The problem is that fat has also a very, very long T2, which means that if you just do a T2 weighted sequence, well, you cannot really interpret these areas of hyperintensity. It could be signs of increase in water T2, inflammation, edema, lesions. It can also simply be fat infiltration. Of course, if you look at your T1 weighted images, you can see that, well, obviously there's a fatty infiltration, fatty replacement component. Is it more? Well, the only way to do it and to know it is to run again a T2 weighted sequence, this time with fat saturation. And this is what the STIR module is. It's to get rid of your fat component, to reveal the muscle tissue, and to be able to detect possible hyperintensities. And it is positive here. Very important, you should always have some sort of internal control. STIR images or whatever, fat saturated, are prone to artifacts. So you should always have a look at an internal control. In adults, the bone marrow, the fat in bone marrow should be suppressed, and also the subcutaneous fat should be suppressed. If it is not properly suppressed, then you can really come to no conclusion. So what about T2? Well, T2 weighting is sensitive, so it indicates that something is going on. It's totally non-specific. Why is it so? Well, it's very simple to understand. The water T2 in the tissue, in the muscle tissue, well, is mainly reflecting the molecular tumbling rate, so the water mobility. And a great many conditions where the water mobility can be increased. It's, of course, it is a case when you have an inflammatory myopathy, whatever the origin. So the characteristics of the signal will not allow you to distinguish between this myopathy. It can be sometimes the distribution of this myopathy that can, for example, help you to point in the direction of an inclusion body myopathy. But all conditions that are associated with an increase in water mobility, and you can think about it in simple terms of edema, will result in increase in T2, and I've listed here a few of them. Necrosis, of course, will increase in the T2. Cell damages, increase cell permeability, as you can have in a dystrophic muscle, will also do it. Hydrostatic edema in a cardiac patient will do that. Denervation, acute and subacute denervation will increase the T2 because of the rapid shrinking of the muscle and the expansion of the interstitial space. And also, and most important to know, that exercise will also increase the water T2, because during exercise of moderate or high intensity, there's really an inflow of water into the muscle. Your muscles are swelling, and it results in increase in water T2. And this is an important consequence. If you want to do your patient evaluation in some sort of comprehensive session, try to always do the imaging before the patient do experimental test or is during other functional evaluation, because these can have an impact on the T2 and can bias your measurement. Difference between a physiological increase in T2, like it happens after exercise, and a pathological increase in T2 is that the first one, the physiological one, is transient. It will disappear in a matter of maximum a few hours, while the pathological one will be almost permanent. And the increase in water T2 is a good indicator of disease activity. Well, it's more with quantitative imaging that you can demonstrate that, but for a disease that can be some sort of a caricatural situation, like a fascious capillary dystrophy, well, where at some point there's some sort of explosive dysregulation of DAX4, well, you can nicely see, even with quantitative imaging, that the increase in water T2, so the stir hyperintensity, precedes and announces the muscle destruction. Look here, you have a very positive stir image in the gastric medialis at the time where the fatty replacement is present but minimum, and look after 6 months or 1 year, well, this gastric is totally destroyed. Another example here, we have positivity in the tibialis anterior, which appear normal. If you come back a few months later, you see that this muscle is now undergoing fatty replacement. This muscle is being destroyed. So this is really the value of stir imaging. It indicates the degree of the disease activity, and is, I would say, irrespective of inflammation. It's more global. Now, current trends. Well, as you all know, whole body imaging is more and more available, more and more popular, and a good reason to try to go for whole body imaging, for the simple reason that the more muscle you can investigate, the higher your chance to identify, to pick up a specific pattern. We've seen that with the improvement in the diagnostic algorithms for the spine rigidity when you go to whole body imaging. Just an example here, you see this patient where you have an important destruction in the thigh while the lower leg is almost intact. When you are in this situation, it's well known that you have to think about two diagnoses, Pompe or sarcoglycanopathy. But if you do whole body imaging, you can also see that a very early stage in group A, where you already have a massive involvement in the tongue, something that the clinician knows very well, that the Pompe patient have a big tongue. And also, if you look at the shoulder, also at an early stage, you have a very significant early and massive involvement of the anterior serratus and the subscapularis, something that you can see here. So going to whole body, particularly here, and for this example for Pompe, you can pick up, if you put everything together, very positive signs in favor of the disease. Now, well, you will object that, well, whole body imaging, it takes time. Yes, it takes time. But on a new machine, on most of your machine now, you have special sequences and protocol to speed up things. Some names that now parallel imaging. Parallel imaging is now present on virtually all machine. Simultaneous multislice is another way that's become more popular. Compressed sensing is a little bit newer. But you have to ask, or you have to activate these sequences to cut down the imaging time. And you have here, when you combine T's possibility, you see that you can really dramatically reduce the acquisition time by a factor of 6.4 in this case. Well, to be practical, one can just say that, well, on modern scanners and using the possibility offered by your system, well, whole body imaging should always be possible within 15 to 20 minutes maximum. And that makes it really compatible with diagnostic procedures. Well, something that is developing, and we'll do that also within the EURO-NMD, is to use all the potential of artificial intelligence, deep learning, to help us to to refine the patterns and to improve their identification. It is an ongoing work, and there are already some interesting results. One cannot totally ignore the impact of the introduction of new generation sequencing. This is illustrated by this slide borrowed from Björn Oud, where let's say in the more classical approach of muscle condition diagnosis, well, in the complex pathway, well, MRI was really frontline. And now with the introduction with NGS, more and more the clinician jumps from the clinical examination to a muscle gene panel. Good or bad, it's certainly a debate that's far from being finished, but it's certainly a fact. So we cannot ignore that maybe the diagnostic use of MR will be slightly or significantly decreasing, will always remain the identification of variants, the confirmation of the pathogenic nature of a gene mutation, also the important use of MR to guide biopsies, all these things will for sure remain. Now, what is developing fast is the use of imaging to really document, benchmark the disease progression, with the idea of using imaging as a non-invasive biomarker of the muscle response to intervention. And it's going to be a major step in the direction of precision medicine. And if you think about these applications, well, this is exclusively the field of quantitative imaging. So instead of looking at the images and giving impression or semi-quantitative grading, here we absolutely need figures, we need values for the three main characterization indices, and this requires other sequences, other approach, which mean, for example, for the fat infiltration, we prefer to use the so-called Dixon sequence, where the separation is really based on the chemical nature of the compound. Water as a resonance frequency that is different than the fat, the methylene resonance, and this allows to reconstruct images that are specifically from fat and water, and then to recombine to a fat fraction. So here, the signal intensity in the image is not arbitrary anymore. It's really a measurement of the degree of fat infiltration. No, we are left with two different, we were left with two different approaches. Well, sequences for diagnosis or qualitative, sequences for monitoring disease and evaluating response to treatment that were quantitative. And it is a pity, because you can be often in this situation. You first see a patient for a diagnosis and you run the diagnostic sequences. And then later the patient is referred to you. Well, you're asking the question, what is the situation? Is the disease progressing? Or this patient is about to be included in a protocol. And then you do the quantitative approach, which is a Dixon. And you're stuck because you cannot compare the qualitative to the quantitative. And there's a solution. The solution, we have been proposing it already some years ago. And it's based on the principle that the who can do more can also do less. So it's simply the fat fraction maps which are quantitative, can also be viewed in a qualitative mode. And you can even take advantage of the quantitative evaluation, well, to facilitate you the clinician task by attributing a particular color to each of the mercury laminin grade. So you can very easily do a qualitative diagnostic evaluation and identification of pattern from all-body Dixon. And we were quite pleased that at the last ELMC meeting dedicated to muscle MRI, not later than a few weeks ago, well, the consensus has been that now for diagnostic imaging, well, the whole body Dixon sequence should be preferred whenever possible. Whenever possible means that when you have it on your machine and when your radiologist is ready to implement this approach. There's no cost in examination time. It remains Dixon as well as a T1 weighted whole body in a modern machine can be performed in a maximum 15 to 20 minutes. So there's no time penalty, and there's a major benefit in terms of your ability to follow you to follow your patient subsequently. And I'm ready to close by simply reminding you or informing the ones who have not received that yet, that very soon we'll have a very nice meeting, nice conference, totally dedicated to imaging of neuromuscular disease. It will be in Berlin in 3 weeks from now, and you are all invited. Coming back to EURO-NMD, as you know, we can make use of the CPMS. We can also make what I call a partial use of the CPMS, so to use part of the many items to discuss imaging cases. And the imaging group with George Tasca, Olivier Scheidegger, Robert Carlier, and myself are ready to help you and to discuss cases with you. If you're HCP affiliated, it's easy. You just have to upload. If you're not, it's possible that you have to ask to get a guest permission. And just to inform you about other activity that we are preparing for 2020, we have in mind for the moment 3 more webinars on imaging. One about the fastly growing field of magnetic resonance neurography by Olivier Scheidegger. We'll intend to update you on the imaging patterns. It will be by George Tasca. And there will be, sorry, it's not imaging, but imaging, there will be also one on the pediatric application by Robert Carlier. And of course, if you have a suggestion, ideas, or if you want to contribute yourself and organize a webinar, you are more than welcome. And with this, I thank you for your attention.